Well, good afternoon. Hello and welcome to the sixth meeting of the All Party Parliamentary Group for Axial Spondyloarthritis. I'm Tom Randall. I'm the Member of Parliament for Gedling, and I am the new or newish chair of the APPG. So I know that you're all very busy people, and I think over the last year you've probably been zoomed out through so many online meetings. So thank you very much for giving up your time this afternoon, and also for taking the time to join us this afternoon to discuss what's a very important subject. Tonight, this afternoon's meeting is going to explore the important area of axial SpA and mental health, the current state of services and the opportunities for improving outcomes in this area. Now, that is obviously an important subject at any time, but I think, particularly given what we've been through over the course of the last year, it is a particularly pertinent subject, and definitely worth our discussion and consideration this afternoon, particularly for those affected by particular conditions like the long-term conditions such as axial SpA. And I know we've all had disruption in our lives, and particularly with swimming pools closed or not being able to necessarily have face-to-face contact with doctors and so forth. It's been a particularly difficult time for those of us with axial SpA. Now, we know that the pressures on the National Health Service have been immense in recent months, and it's likely to be like that for the foreseeable future as things begin to recover and start to get back to normal. But we've got to ensure that areas that have been traditionally under-prioritised, such as axial SpA and mental health, are better incorporated into policy planning and priority setting as we go forwards. And to present the best case to parliamentary and NHS colleagues about the importance of this, it's very important that we have the robust evidence and practical solutions in place about how things can be improved. So to that end, I'm delighted to be able to say that we can welcome 5 expert speakers this afternoon who are going to be able to present to us on a range of key aspects about axial SpA and the mental health debate. And I'm sure that these speakers will give us a really good sort of food for thought on the issues involved and what it is that we should be looking forward to achieving in the future. We're going to listen to we're going to hear the 5 presentations. There's also going to be an opportunity for a group discussion in the second half of today's meeting. And you should find at the bottom of your screens, I'm sure you're all used to Zoom now, but you should have a chat function and a Q&A function. If you've got a question or you want to contribute to the discussion, please use the Q&A function button, and that will help. We've got the sort of sprites and elves backstage who are helping to marshal all the questions together, and that will just help them to sort of bring everything together. So that will be great, and will be, as I say, Dale Webb, who's joining us. You should be able to see on your screen as well. He'll be leading the Q&A session in the second half. I should also just say that this is, as you've probably seen you may see from the recording sign, this is a recorded session. So just to let you know, we're recording this, and this will be available for those who haven't been able to attend today's session. So there's a lot to go through, but before we get to our first speaker, I'd just like to hand over to Dr. Dale Webb to provide an update on the work that NASA has been doing over the last few months. Dale.
Many thanks, Tom, and thanks to all our colleagues who are joining the APPG meeting this evening. I want to make 2 brief comments by way of context. The first, as Tom said, is that COVID itself is an important context for this meeting. And whilst we've all, I'm sure, felt challenged in many ways by COVID, for people with axial SpA and other rheumatological conditions, this has been a particularly taxing time. And if we go back 12 months, when the guidance first came out around patients having to shield, the confusion and uncertainty about which patients should shield and shouldn't shield. We know of many examples of people who were told conflicting information from their rheumatologist on the one hand and their GP on the other. And of course, as COVID started to bite and clinical staff were redeployed onto COVID wards, many rheumatology departments simply couldn't provide the same level of service as a consequence. So it's a very distressing and confusing time for patients, and they came to patient organizations in their droves. And there was an international research just presented this week at a conference on Monday, showing that during the pandemic across European countries and including in the UK, when you ask patients in rheumatology which has been the top source of information and support for you during the pandemic, the top answer was patients and organizations. And here at NAS, for example, with the huge increase in our helpline calls, we doubled our helpline opening hours, we employed additional staff. And if you look at the metrics of the numbers of people who have been using our services as a consequence, so just brief examples, our COVID web pages have been reviewed 50,000 times. We set up some weekly Facebook Live sessions to help reduce the isolation that lockdown caused. And the videos from those have now been seen 135,000 times already. We're piloting new self-management projects in collaboration with rheumatology departments. And of course, our NAS branches have been working hard to provide virtual support. So patient organizations have been playing, I think, a critically important role during the last year. So COVID is one part of the context, but the broader part of the context, of course, is around mental health and axial SpA more generally, where we know that about 2/3 of people with axial SpA will have some mental health problems, and around 1 in 6 will have significant depression. Now, that's higher than the general population, but it's also higher than other musculoskeletal conditions. And we know from the evidence that the impact of having axial SpA and mental health can significantly impact on people's personal relationships and on their employment. And there's some new research, I think it's been published or about to be published, which shows that people with axial SpA who have mental health problems will have significantly poorer outcomes on biologic therapy than those who don't have mental health problems. And of course, as context for us, in 2019, the APPG published a report showing that only 1 in 4 NHS trusts were able to offer direct access to psychological services from rheumatology. And we know too about the important interrelationship between physical and mental health and the need to treat the whole person. So in summary, there is a significant burden of disease, of mental health conditions which are not being identified and well managed. And therefore, this evening's meeting is a critically important opportunity, I think, to explore ways of addressing this important deficit. Thank you, Tom.
Thanks, Dale, and yeah, some very interesting statistics there actually. So thank you for that. So we'll go on to our first presentation of the evening, which is by Paul Curry. He's a NAS trustee, and he's going to be speaking about his own experiences of living with axial SpA. Paul.
Good evening. Thank you for inviting me to talk about some of the issues surrounding mental health and chronic pain, and specifically mental health in patients with axial SpA. My name is Paul Curry, and I am 39 years old, and I have axial spondyloarthritis. In order to discuss some of the issues surrounding mental health and axial SpA, I feel it is appropriate to tell you a little bit of my story and the reasons why I'm sitting in front of you today. The onset of my symptoms began when I was only 14 years old. When I look back at those times, I was a very active teenager, playing sports 7 days a week. Leading up to the onset of my symptoms, I was a happy child with no troubles, no worries, no concerns about how life would pan out. Like every sporty child, I had dreams of playing sport professionally, or at least at the highest standard that I could achieve. My friendship circles were all people of similar walks of life, people with similar aspirations of a sporty future. At 14, everything began to change for me. I clearly remember being on the rugby field at 14 and not being able to get back up after a tackle. Like any young kid, especially one trying to make his way in a new school, I tried to shake it off. The pain was a dull ache and would come and go with the help of ibuprofen. But it was the most embarrassing time of my young life. To crawl off the field in tears and not to be able to explain what was going on to people was hard. This scenario would repeat itself as I went through my school and university years. I went in and out of pain cycles, some days able to walk, run and play sport with my friends, and other days not able to get out of bed or put my clothes on without crying. I was anxious, tired, and in terrible pain. Why was I different from everyone else? Why couldn't I roll over in bed without screaming in pain? Why couldn't I get dressed in the morning? I could see the feeling of sorrow in my parents' eyes too. They were also at a very low point in their lives because of what was happening to me. I was in and out of GP surgeries more times than I could keep track of. Unfortunately, I never left with a diagnosis or reason for the pain. Referral after referral to pain management clinics, orthopedic surgeons followed. Surgery was discussed many times, and in between discussions, I was given regular steroid injections. The relief was short-lived and the pain cycles continued. I became a very unhappy child, even when I was in less pain. I left Durham at the age of 18 to head to university in Leicester. It was here, though, that things started to deteriorate rapidly. I started to notice that I was closing myself off from social occasions. When I did socialize, I would drink more than others to dull the pain. I was drinking 4 to 5 nights a week. I knew what I was doing wasn't right, but I couldn't cope. I was heading towards a dark hole. I began to have discussions with my friends about the state of my mental health, but in the early 2000s, it was still somewhat of a taboo subject. I was in chronic pain without a diagnosis, so how could my friends help? I discussed how I felt mentally with my GP, but it was all related back to the pain I had, and once they could cure that, my mental health would improve. I started missing lectures as I couldn't walk. I was lost. I was completely lost in a world of pain. The next few years were a real blur. I managed to scrape through uni with a degree, but I was rarely happy, and I knew I couldn't continue as I was. I was around 26 and living back in Durham at the time with my now wife. I was working for my family business, which was the only way I could find a sympathetic employer whilst in and out of flare-ups. Another private physio recommended I go and see someone they trusted at the Freeman Hospital in Newcastle. I asked my GP for another referral letter and I was back in the NHS system again. Within weeks, I had a diagnosis of ankylosing spondylitis. Unfortunately, my disease had progressed untreated for so long that I now not only live with AS, but also the irreversible damage that the undiagnosed AS had caused to my spine. My lower back and hips are fused. That causes tremendous problems when it comes to stretching with muscle spasms around the spine, and there is little to no flexibility there whatsoever. I still live with pain. Whilst treatment for the disease was immediately in place, it is only now that I look back when there was so much wrong with me. My mental health was at rock bottom. It was enlightening to have a diagnosis of axial SpA, but also very scary. The support I received and still receive from the Freeman Hospital in Newcastle is phenomenal. If I am ever in a flare, I make one quick phone call to a specialist nurse and they usually see me the next day. I can't thank them enough for everything they do for me and for other patients in Newcastle. At 39, I still have flares. Even after a flare, the pain rarely goes away. Like with all chronic pain sufferers, you just find ways to manage. But in those times of pain, my mental health suffers enormously. Sadly, for whatever reason, my mental health has never been addressed, nor has there ever been a clear pathway to any services or support with regards to my mental health. This includes post-diagnosis. Whilst I feel like I will always have the support of my wonderful consultants, they don't appear to have the resources to address my mental health concerns. I am now the director of a company which employs over 120 people and with a fantastic wife and 3 children. As much as they put a smile on my face, I will be the first to admit that every day is still a struggle. Getting 3 children dressed for school whilst also trying to dress myself is more than a challenge on many days. There are times when this all becomes a little too much for me, and my wife is the person that pulls me away from those dark clouds which hover over people with axial SpA. Like all chronic pain sufferers, I will probably always deal with mental health hurdles, and as a result of the physical ones being placed in my way every day, it will always be a struggle. The cost to the people I employ is immeasurable, and time away from work, if my mental health does deteriorate too much, would be devastating to them. I have been very fortunate in so much as I work in a family business, but there are thousands of people who don't. And I'm not sure how they explain to their employers that they can't come to work that day because of how they feel because of their axial SpA. I can only imagine that for some people, work for this very reason becomes untenable and they don't even attempt employment. To have access to mental health support would be a real game changer for me. To be able to know that this support was at hand at any time would take a huge burden from my shoulders. The fear of letting people down at work or letting family and friends down at home is immeasurable. Thank you.
Thank you, Paul. I seem to be having some video problems. Okay, start my video. Okay, sorry about that. Thank you, Paul, for sharing that story, and particularly must be a very difficult story to share with people. So thank you for doing so. I'd like to now introduce the second of our presentations, which is from Dr. Sophia Steer, who is a consultant rheumatologist from King's College Hospital Foundation Trust, and she'll be providing an overview of the new research into the emotional impact of living with axial SpA. Dr. Steer.
Good evening, everyone. My name is Sophia Steer, and I'm a consultant rheumatologist working with colleagues from King's College Hospital and King's College London on a NAS-funded project focused on exploring the emotional impact of axial spondyloarthritis. This evening, I'm going to present some early findings from the first phase of our project, and I'll then say a little bit more about the second phase, which we're due to start shortly. Many people with axial SpA experience psychological distress. We know that depression is more prevalent in people with axial SpA than in control populations, with about 40% of people reporting some depressive symptoms. Pain, fatigue, and disability, which are common characteristics of axial SpA, may contribute to feelings of helplessness, social isolation, anxiety, and depression, with some research showing that the risk of depression is highest in the year following diagnosis. When people with axial SpA are asked about the burden associated with their condition, they commonly report emotional aspects, yet these emotional dimensions of illness are frequently overlooked during healthcare consultations. Emotional well-being is a core component of our subjective well-being. Positive emotions contribute to upward spirals, increased coping, and lead to increased use of personal resources and resilience. The experience of negative emotions, on the other hand, is commonly associated with a downward spiral, narrowed thinking, and worsening mood. Higher levels of positive emotional well-being are favourable associated with physical illness prognosis, and as such, fostering emotional well-being in people with axial SpA may potentially influence long-term outcomes. So, our project seeks to deepen our understanding of the emotional impact of living with axial SpA and to identify facilitators and barriers to positive emotional well-being. Phase 1 of our project had 2 parts. First was a systematic review of qualitative studies in the peer-reviewed literature, where the study population was people with axial SpA and there was data about emotional experiences or the psychological or emotional impact of their condition. We screened over 10,000 records and identified 27 studies that met our inclusion criteria, 13 of which we have synthesized to date, as they are particularly relevant to the project aim with having increased richness of emotional data. The second part was a review of online social media, including the NAS forum, Facebook, Twitter, Instagram, and public blogs, visited and accessed by UK NAS members. We screened posts to June 2020 and identified 500 that were relevant. In the first part of our study, The 13 studies that we've included and synthesized were published between 2001 and 2019. They included 435 participants, 25% of whom were women only. They had established disease and were generally in the 4th and 5th decades of their lives. The majority were categorized as having ankylosing spondylitis, and 8 studies were UK-based, with the others being in Denmark, France, and Turkey. None of them were primarily focused on emotions. We found that together the studies provided a dominant narrative about the adverse impact of axial SpA on emotional well-being. Symptoms associated with pain, fatigue, and sleep disturbance were linked with expressions of frustration, fear, helplessness. It will come as no surprise that our review identified that a lack of authentication of participant symptoms and experiences by healthcare professionals, stigmatization associated with the presentation of back pain, and delayed diagnosis were substantial barriers to participant positive emotional well-being. Restricted engagement in previously enjoyed physical and social activities led to withdrawal and isolation, while work inability or job insecurity secondary to needing to take time off because of symptoms caused worry and feelings of depression. For participants taking anti-TNF therapy, withdrawal of treatment or the possibility that it would stop working was a major concern, and there was a reactivation of fear, annoyance, and depression on occasions when participants re-experienced symptoms of active disease. Conversely, positive emotions and facilitators to emotional well-being were associated with receiving a definitive diagnosis, although obviously for some participants, the diagnosis engendered worry and discouragement about the long-term nature of their condition. 3 studies included in our synthesis focused on eligibility for and treatment with anti-TNF therapy and experiences of regular exercise. These identified clear positive emotions associated with these interventions: hope, happiness, a more positive outlook due to improved function and workability, and relationships characterized by fewer mood swings and less irritability. Exercise led to increased personal self-esteem and pride, with affirmation from others supportive of emotional well-being. Having sufficient knowledge about symptoms and being informed about axial SpA reduced worry and anxiety, while supportive networks of families and friends were associated with positive emotions. Moving on to the social media review, in addition to the key concepts associated with emotions identified in the peer-reviewed literature, we gained further insights into the emotional impact of axial SpA. 52% of posts were from men, with negative emotions associated with 63% of all coded posts. We categorized posts encapsulating emotions as relating to 4 key themes: daily challenges, self-concept, which is how someone thinks about, evaluates, and perceives themselves, professional and personal relationships. The text in black encapsulates sub-themes with negative emotions, and the red text that with positive emotions. Pain was a barrier to positive emotional well-being across all 4 categories. In relation to daily challenges, symptom variability and unpredictability were either met with acceptance or resulted in frustration. For many, trying to balance daily commitments with treatment regimens and variable symptoms was disruptive and led to feelings of guilt and being overwhelmed. Medication side effects were a worry, although people who were satisfied with their medication regime reported a more positive outlook and coping. In relation to self-concept, overcoming hurdles associated with the disease led to pride and positive emotions, while changes in physical appearance, difficulty accepting being unable to do some of the things that could previously be done, were associated with more negative self-evaluations. Under the theme of professional relationships, a lack of acknowledgement and understanding from employers or organisations about axial SpA or symptoms when a diagnosis had not yet been given led to feelings of vulnerability and anxiety. Conversely, reasonable adjustments, when put in place, were supportive of positive emotional responses. Finally, under the theme of personal relationships, difficulties fulfilling the role of being a mother because of axial SpA-related symptoms and a lack of understanding of the condition from friends and family negatively impacted emotional well-being, while having strong support networks played an important role in coping. The next phase of our study will be diary interviews and 4 focus groups. The review of the literature and the social media platforms thus far has been useful, but we are missing evidence about emotional well-being early in disease and immediately following diagnosis. So the people who participate in these interviews and focus groups will either be recently diagnosed or in the first year post-diagnosis. To encourage participants to express a range of emotions, they will draw on 2 emotion wheels, one of which you can see on this slide, to act as prompts, which we hope will be useful. The focus groups will further explore the concepts and ideas related to emotional well-being that are brought up in the daily diaries. So in summary, our review has highlighted the negative emotional impact of axial SpA across the life course. We've identified the experiences of a substantial number of people with established disease, with consistency around barriers and facilitators to emotional well-being. However, there is limited data and understanding about the experiences of people from diverse backgrounds with non-radiographic disease and with early disease in the peer-reviewed literature. We hope to try and partially fill this gap through phase 2 of our study and through the creation of a brief animation to raise awareness about the emotional impact of living with this condition. Most people with axial SpA are diagnosed in their 20s and 30s, a period in life when work, relationships, and personal identities are becoming established. Supporting people with axial SpA towards emotional well-being and managing negative emotions positively from the outset offers opportunities for better outcomes. It remains for me to highlight the work of the project team, particularly that of Nikki Wilson, who has led this, but everyone on this slide who's contributed enormously to the project so far, and of course to NAS for their funding and support. Thank you.
Thank you so much for that really interesting presentation. I think the emotions that you described there will be familiar to anyone on this call who does have AS. So that was a really interesting insight into the experiences. Thank you for contributing to the chat function. Just a reminder, we have got the Q&A at the bottom of the screen. So if you do want to contribute to the Q&A, you've got questions or answers, please do use the Q&A function that's at the bottom of the screen. If you do want to use the chat, there is an option to not only to send a message to all panelists, but also send it to all panelists and the attendees. So if you do want to have a sort of make a broader comment to everyone who's here, do select the all panelists and attendees option when you're sending your message. But do keep the comments coming through and keep the questions coming through as well in the Q&A section of the Zoom meeting. So following on from Dr. Steer, we're going to go on to our third presentation this evening, which is from Dr. Ben Thompson. Dr. Thompson is a consultant rheumatologist working at Newcastle Hospital's NHS Foundation Trust, and he's going to present on current service delivery and his thoughts on where the opportunities for improvement lie. Dr. Thompson.
So good evening. Firstly, thank you very much for the invitation to speak, both from NAS and from the APPG for axial spondyloarthritis. So I'm Ben Thompson, so I'm a rheumatology consultant in Newcastle, and I've been asked to talk about current practice in axial spondyloarthritis and mental health. So I've certainly focused on the current practice from a Newcastle point of view of what resources we can access as a rheumatology department for people with axial spondyloarthritis, and also think a bit about what best practice might look like in this area. So as I said, I'll look at the Newcastle spondyloarthritis service, think about what routes that we have as rheumatologists for accessing health for people with SpA and mental health problems, and think about the role of the rheumatology team in good practice. So the Newcastle spondyloarthritis service is quite large. It covers quite a big geographical area. There's 4 rheumatology consultants, so both myself and Leslie Kay, Ijaz Pathan and Rachel Duncan. There's a specialist nurse, Michelle Rutherford, an extended scope physiotherapist, Maureen Motion, who runs a screening clinic for inflammatory back pain and leads the hydrotherapy and physiotherapy services. And also an occupational therapist, Gemma O'Callaghan, who I'll come back to when I talk about the resources that are available for patients in this service. And as a spondyloarthritis service, we're really pleased to be part of the NAS Aspiring to Excellence programme, which I'm sure many of you are aware of. So you've heard Nikki Wilson talk about some of the evidence around axial spondyloarthritis and mental health problems. From my perspective, I'm certainly very aware that this is a common problem. So a recent review article has suggested about 1 in 6 people with axial spondyloarthritis has significant depression, and probably up to 2/3 of people have some form of mental health problem. So certainly in excess of the sort of normal population or people without axial spondyloarthritis in terms of mental health problems. And certainly I've seen that it can be absolutely devastating for patients in terms of their overall life and the impact on the disease as well. So having anxiety or depression can also change the way people fill out questionnaires around their disease activity levels. But actually we do ask about some of these issues and some of these outcome measures. So there's the ASQUAL questionnaire, which is an ankylosing spondylitis quality of life questionnaire, asks around things like, does your condition get you down? Does it limit what you can do? And also an MSKHQ questionnaire also asks about anxiety and depression. So we do have access to this sort of information. I think it's more about how we respond and how we best help people who do sort of report these problems. People with mental health problems can certainly be effectively helped through psychological and sometimes medication intervention. So it's important that we know about them and we can help. But actually, in terms of the guidelines, both nationally and internationally, for axial spondyloarthritis and how we should be treating them, mental health doesn't really play a big part in those guidelines. So I've mentioned that sometimes we can find out about these problems through questionnaires, but actually we find it difficult, I think, as a rheumatology service and rheumatology professionals to know the best way to help people. I think it quite commonly comes up, actually. I think increasingly as rheumatologists, we'll know our patients better than the GP and the primary care team does, and some patients won't see a GP through choice or will have a regular GP. But actually we don't have a lot of training in mental health support, so certainly not much since medical school. And also if we do refer, then the services that are available are variable from region to region and aren't necessarily rapid in terms of providing help for people, which can be frustrating. Also, if we did decide that we wanted to provide more mental health support for our patients, then actually kind of persuading managers to provide funds to do this can be challenging, as it's seen as something that's separate from the care of people with rheumatological problems, which is more physical help. So it can be difficult to increase the amount of support we can give them ourselves. So what's available in Newcastle? So as I mentioned before, there's a rheumatology occupational therapist as part of our team, Gemma Callahan, who's fantastic, who can see people who have got issues like needle therapy or are struggling to adjust to their condition, and she can use this alongside kind of education around the disease. She's got training in cognitive behavioural therapy and has a supervisor who's a health psychologist. So if she does run into problems, she can escalate problems up. We're also very lucky in Newcastle to have help from clinical health psychology. So a recent audit of rheumatology units in the UK suggested around 40% of rheumatology units have access to health psychology. And the psychologists can do one-to-one help with people who have more complex needs that are impacting on their care and their physical health as well. So really very helpful for people with more greater need than the occupational therapist can do. So for people with longer term depression, anxiety, sometimes things like alcohol or substance abuse will be referring back to the GP and having some dialogue with the GP about the issues that have come out in a consultation. We can also signpost patients to some self-referral resources. So most areas will now have some sort of talking therapy service, and this is the case in Newcastle. So patients can self-refer via the internet. And for really serious problems that when we see people in clinic or elsewhere, there's a crisis team which is available 24 hours a day with psychiatric help. So psychiatric nurses and psychiatrists, perhaps if they need intensive treatment over the next few days or need admission, we would call them. I think it's also important to say, actually, things like health psychology at the moment are probably under additional strain. So I checked recently, and it's an 8-month wait now for a health psychology assessment. So that's not treatment. And that's because some of these professionals have been sort of transferred over to help with staff who've been looking after COVID patients. So again, it's not a rapid solution for people's problems referring to health psychology. So finally, just a thought about what best practice might look like. So I think as a minimum standard, as rheumatologists and rheumatology nurses and the rest of the team, we should be able to effectively identify people with SpA who are at risk or have mental health problems, and be aware of what resources are available locally so that we can refer people appropriately. I think if we talk to the people that we're referring to about the problems that we're facing, then actually you can improve the service that people have and maybe set up referral pathways for rheumatology patients or people with axial spondyloarthritis. I think we need to take opportunities like this to think about actually, which units have done something different or trying something different, and could other units, the rheumatology departments, take that on? And I know there's certainly centres where there's more health psychology input than we have, which I'm sure will be excellent. Actually, do we need to think about mental health support and treatment being included in guidelines? Are there opportunities for nurses and doctors and physios to actually have more training in how we support people who have got mental health problems? And actually, do we need to integrate mental health support through psychologists more in a greater depth in our rheumatology services? So those are things that I think we could think about. I'm sure other things will come out in the course of the debate today. Thank you.
Thompson, thank you for that presentation. Having once, I used to live in Newcastle. I was a patient there, so I know there's a great team up in Newcastle. But it's great to hear the other things that you've been doing and the way that you're taking this forward and developing your approaches there. So thank you very much for that presentation. We now go on to our fourth presentation of the afternoon, which is from Dr. Max Henderson. Dr. Henderson is an Associate Professor of Psychology at the Leeds Institute of Health Sciences, and he's going to present to us on the perspective of mental health professionals and how the management of long-term conditions can be improved. Dr. Henderson.
Good evening, and thank you very much for the invitation to speak this evening. I'm Max Henderson. I'm a psychiatrist in Leeds, and I want to talk to you about the wider role of mental health professionals in managing physical and mental health. I'm a liaison psychiatrist, and that means that my team work very closely with people with physical health problems. My team works in the general hospital, both in inpatients and outpatients, and we work alongside our colleagues in medicine and surgery, assessing patients, making diagnoses and assisting them with management plans to deal with the problems presented by the relationship between physical and mental health. A number of us are trained both in psychiatry and hospital medicine, and therefore are acutely aware of those challenges. Musculoskeletal disorders and common mental disorders can occur together, that's comorbidity, but I want to open this up into a wider discussion about multimorbidity. This is where two or more long-term conditions exist alongside each other. Long-term conditions are those which can't be cured, but instead need to be managed. Much of the research literature is focused on long-term conditions and multimorbidity in the elderly population, but it can occur at any age. I've given some examples of long-term conditions there, and you'll see and be familiar with many of them. The important thing about multimorbidity is it's neither rare nor special, but I would argue is common and almost normal. Our difficulty getting our heads around it is sometimes because medicine is taught by specialists who know a huge amount about their subject, though less about others, and therefore we learn in silos rather than being taught to identify and manage one condition when it presents in the presence of another. Clinically, that can be challenging sometimes, but it's the day-to-day bread and butter work of my team, and I'm certain that it can be done. We are much less interested at this stage in whether one condition causes another, but the presence of a second or third condition can make the management and treatment of the other conditions more difficult. I just want at this stage to raise the issue of social disadvantage here, because multimorbidity is something that exists on a steep social gradient, with multimorbidity having been much more common and creating much greater difficulties for those people who are disadvantaged and sit at the bottom of society, particularly when it comes to issues about employment and housing and income. It's important to recognise that conditions that occur together can either influence each other or not influence each other. I would argue that musculoskeletal disorders and common mental disorders, when they exist together, have a significant impact on the other. And I've given some examples here on the slides in front of you. Pain and sleep and energy and motivation are very much impacted in one condition by the presence of another. I also want to draw your attention to two other malign complications that I've observed. The first is social isolation, which can occur when mobility problems are significant, or when mood problems are significant, and social isolation makes getting better much harder. In addition, musculoskeletal disorders and common mental disorders are the primary reasons why people fall out of the labour market, and the presence of one disorder can make staying in work very much harder when the other disorder comes along. For example, the impact of depression on the experience of having a painful musculoskeletal disorder can mean that symptoms are experienced as more painful, can impact on other symptoms such as pain, and the ability of patients to manage those symptoms when they are depressed is very much harder. We know that the employment rate for people who have both musculoskeletal disorders and common mental disorders is about half of that of people who've got musculoskeletal disorders alone. And in my experience of working with rheumatologists and occupational physicians, the additional presence of a common mental disorder like depression is often the tipping point that leads to employment difficulties for someone who's otherwise managed their musculoskeletal disorder fairly well. Of course, once someone ends up on sick leave or leaving their job, that makes things even more difficult. They certainly doesn't help get their depression or their arthritis better, and can create additional problems in terms of isolation and financial difficulties. Social isolation causes everything to get worse. Mental health services, I'm afraid, are not always best placed at the moment to help patients in these situations. Mental health services remain underfunded, despite some recent increases in funding, and particularly mental health research when compared to other areas such as heart disease and cancer is hugely underfunded. There are aims around creating a parity of esteem between physical and mental health, but we still have quite a way to go there, I'm afraid. Mental health services in the UK are rather scattergun, and we have primary care services, secondary care services, third sector services, but they don't particularly exist within a helpful framework that allows people to access the services they need when they need them. I have to tell you that before COVID, mental health services were overwhelmed, particularly my colleagues who work in community mental health services, and of course the pandemic has made things even harder, both with patient and staff difficulties. The way services are aligned in the UK often fails to meet the needs of patients who have got multimorbidities between physical and mental health problems. Mental health services are primarily designed to focus on risk, unfortunately, as opposed to clinical need. This is a historical challenge, and one that tends to be more of an issue, for example, with patients who have psychotic illnesses. But that focus tends to draw mental health services into treating what's seen as urgent rather than what many of us would regard as important. And the best example to illustrate this is the focus that, for example, that occurs in crisis services, some of which exist in emergency departments, but there is relatively little development in the services like mine that provide mental health support, diagnoses and treatment to patients both in hospital and in outpatients who've got pre-existing physical health problems. How are we going to make this better? Well, education and training, of course, are important, both for doctors and other disciplines at undergraduate and postgraduate level. We all need to collaborate better, and we need to communicate better. But we've talked about this before, and it still hasn't shifted the difficulties. My sense is that the challenges faced by patients with both a musculoskeletal disorder and a common mental disorder are not going to be solved by making better psychiatrists of rheumatologists or better rheumatologists of psychiatrists. We need a new why, we need a new purpose, and we need to decide what medicine fundamentally is for. I would argue that we need to move beyond symptom alleviation, something I know my rheumatology colleagues are familiar and comfortable with, and we need to move to optimizing function. We need to think about what the patient is hoping to do once we have alleviated their symptoms. For many people, that might be returning to work. For others, that might be aspects of family or social life. Work as a health outcome is a good example of where health and policy have come together, and this we need to make more of this opportunity to identify areas of function where we can come together as clinicians. In doing so, we move beyond the boundaries of our own specialties to create a shared endeavour with our colleagues. To achieve this, we will need the input from colleagues in other specialties and in primary care to get the best for our patients. Meaningful collaboration and communication will not be optional extras, they will be essential. And I think if we could get this moving within the area of musculoskeletal disorders and common mental disorders, we can act as a template for the wider world of multimorbidity. Thank you very much indeed.
Dr. Henderson, thank you for that insight and sharing your thoughts on this issue. We now come to our final, last but by no means least, presentation of the evening, which is by Sue Brown. Sue is the CEO of the Arthritis and Musculoskeletal Alliance, and she's going to be providing the Alliance's perspective on the future of MSK and mental health care. Sue.
Thank you very much. And I'm very pleased to be here today because mental health has been a priority for ARMA for a number of years. I think this is a really, really important meeting. ARMA is the Arthritis and Musculoskeletal Alliance, and we bring together both patient and professional organisations to work for improvements in musculoskeletal services. And as I said, mental health has been a priority for us for quite some time. And in 2019, we held a roundtable on mental health and MSK, bringing together both mental health stakeholders and musculoskeletal stakeholders. That event was chaired by Paul Farmer, the CEO of Mind. And on that day, we discussed issues and we discussed some possible solutions. So as Dr. Henderson has just said, the first really important thing is that pain, mental health and disability are all interlinked and they all impact on each other. They're not separate things. The roundtable identified a number of things that make mental health worse for people who have MSK conditions. And I think we've heard from several speakers things that will resonate with this today. Number one was long delays in diagnosis. Knowing you have something wrong with you, but not knowing what is a very difficult thing to cope with. A second one that was highlighted was feeling like you're the only one. And I think this is one of the reasons why ARMA is so keen on peer support and the importance of bringing people together who are having similar experiences. And then a third one that we identified was transitions. So when things change, when things move, it's much harder to cope, and it's much harder to cope with your mental health. And people with conditions like axial spondyloarthritis will experience a whole series of transitions. So first of all, you get diagnosis, and you may have several misdiagnoses before you get to the correct diagnosis. You may well have a number of flares. You will experience changes in medication as you try to get that right. And then both starting and stopping work are really important transitions. All of those changes make it harder to manage mental health. The roundtable came up with 4 really important recommendations that we wanted to make, 2 for services and 2 for individual professionals. So around services, people will probably be aware of IAPT, the increasing access to psychological therapies, which is about addressing people's anxiety and depression. IAPT began just focusing on anxiety and depression, but there is now IAPT for long-term conditions, which is looking at anxiety and depression in relationship and comorbidities with other long-term conditions. Some of the IAPT services, sadly very few, have worked specifically on having some competencies around musculoskeletal pain and anxiety and depression. And those services have done some fantastic things, linking in with pain services and linking in with kind of social prescribing grassroots patient organisations. So that as people need maybe stepping up to a more intensive support, or can be stepped down to peer support, they're able to do that. There are some fantastic examples out there, sadly not enough of them, and we would like to see those more widely available. And the second one is integrated mental health support. We don't think, and the roundtable didn't think, that this should be about, oh, now you've come to see a rheumatologist who will make a referral to mental health services, as though those two things are completely separate. And there are some great examples of services where health psychologists are actually working as part of the team within rheumatology. So it doesn't feel like it's a separate service. It's people with an understanding of both. The recommendations were for professionals were, the first one is just ask about mental health. I think that that's important. raise those issues. Don't just talk about the condition and the rheumatology aspect of the consultation. There are lots of reasons why musculoskeletal professionals find it difficult to do that. They generally are not trained in mental health during their initial training, and they're very worried about opening a can of worms, something coming up that they don't know how to cope with, and knowing that the mental health services are, as we've heard, really difficult to access and to make referrals to. Where you have health psychologists working as part of the team, what people find is that the rheumatologist will be much more confident about doing that. They become more confident about talking about mental health. And then the second recommendation that the roundtable would make for professionals is signpost to patient organisations. And it comes back to that peer support. Organisations like NAS have a massively important role to play in bringing people together who are all experiencing the same thing for peer support. It makes so much difference. Just making sure that patients know about whichever is the relevant patient organisation for their condition, so that they can get in touch and find out what support is available, is really, really important. So those were our roundtables for simple recommendations for moving forward on this issue. So I am really delighted to be speaking at this event. I'm really delighted that this issue is being highlighted, because it is so important, and I'm really looking forward to hearing the discussion that will follow these presentations. Thank you very much.
So thank you for providing that insight and for giving your thoughts on that. That's really appreciated. So that concludes the presentation half of this afternoon's event. So I'll hand over now to Dr. Dale Webb, who will start the group discussion part of our evening. Dale.
Many thanks, Tom. I think it's been an incredibly rich set of presentations already. I've certainly learned many things that I wasn't aware of before, and I know we'll want to explore these over the next 45 minutes or so. We began with Paul telling us his story, and I know there are many people with Axial SpA who are listening to this discussion tonight. Some of you will feel comfortable sharing your stories, and some of you I know won't feel that you're in a place where you can do that. But I do want to invite now onto the stage people who've given their consent to be involved in some of the discussion. If we can please bring back onto the stage Paul Curry, and also Francis Reed and Raj Mahapatra, that would be very much appreciated. We bring Francis and Raj. Wonderful, they're joining us now. That's great, and Raj will be here, I'm sure, any second. Thank you, Paul. First of all, thank you for your presentation. You said many candid things that were striking. You talked about your life pre-diagnosis at university. You said you were heading towards a dark hole. You were completely lost in a world of pain. And you said, in those times of pain, my mental health suffered enormously. I want to ask, first of all, Francis, when you were listening to Paul's story, were there things that resonated for you, or things that were different in your experience?
A lot resonated, and it even brought tears to my eyes. I mean, if I say in the middle of last night, I was awake between midnight and 4 AM this morning. I had taken all the painkillers that I could, and was just sitting there hoping that something would change. Yeah, a lot resonated. I mean, for me, my diagnosis was 11 years coming. And in that time, I tried battling on through work. I tried to keep my various difficulties away from work. I had a a knee injury that wouldn't heal, which I now totally believe was related to the SpA. I had back problems, I had shoulder problems, but I kept on battling through. I was on crutches for 6 months. I was flying to meetings, but I just tried to keep it going, and I couldn't. And I ended up having a breakdown. I was signed off work. I was diagnosed with anxiety and depression. Work were brilliant. They said, take as long as you want. But actually for me, having had some counselling, I decided for me, actually, the thing that was frightening me the most was having a time limit on getting better. So I decided to leave my job, and I did, which was really hard. It's turned out fine since then, and I am back working, and actually working alongside somebody I worked for at that time. So it did work out, but it did give me time and space. No, it helped improve my symptoms for a while because I wasn't pushing myself quite so hard, but it still went on. Later on, when I was actually properly under rheumatology, but they still hadn't worked out quite what was wrong, I had a bit of a bad time. My mum died, and my consultant was wonderful, and I had a bad time sort of helping look after her in her final days. And he would question me every time, and he phoned me up and said, how are you doing, and do you need any help? Sorry, my dog's joining in. And I said, no, actually, it's not the same as before. This is different, but thank you. I really appreciate you asking. Sadly, he's moved on, and nobody's asked about my mental health ever since. So a lot resonated with everything that all the speakers said. It's been really useful, really interesting.
Thank you, Frances, for sharing that story. And it's interesting that in both your comments and Paul's and some of the chat I can see here, and people are talking about the impact of mental health and SpA on people's employment. I was really struck by a comment in Max's presentation. Max said the employment rate of those who have a musculoskeletal problem and a common mental disorder is half that of those who've got musculoskeletal disorder alone. There's clearly a huge amount that we need to be doing to support people to be in their workplace and to support them with times of mental distress. Raj, listening to those two comments from Paul and Frances, what resonates for you and what's different in your story?
What's interesting for me is that, I mean, Paul, everything you said just rang so true, even down to, finding yourself drinking too much in order to take away pain, and finding yourself fall back into that when you have pain still. And I know so many people who do that, and I know I'm one of them. Who from time to time has a drink just because it hurts a bit too much, and you hit the medication point where you can't have any more medication. I think that relationship between pain and mental health cannot be understated, though. I mean, we've talked about it all, and to hear everyone kind of repeat it again and again has been brilliant, and it's made a huge difference to me hearing people actually recognize that. Knowing that pain can pass in itself can lift your spirits, however bad the pain is. But sometimes the pain is so persistent, it feels unending. And for me, with the added stress that we've got in life right now, even though I've had almost 30 years of living with the condition, and knowing I have all these different practices I have in play to manage the condition, right now with the added stress of what we have going on at the moment, my symptoms have increased well beyond how I normally function. At best at the moment, the pain is a thumping ache, and at worst, it's causing nausea. It's sending stars across my vision. It's meant that I find myself constantly on the edge of tears, and this has led me to questioning my worth at times. You really wonder why people will listen to you when you're almost in that kind of state of mind. And then that increases your anxiety, and then your symptoms increase more, and then you feel worse. I mean, luckily for me, the company I work with provides mental health support for all its staff, regardless. And on top of that, last year when I was recommended to take some time off by my mental health support, my company supported me with that action, and they allowed me to take a month off work. I'm really aware that I'm really lucky that I don't have to make that choice about stopping work to look after myself. And even knowing that my company has my back, it's been a struggle. My heart absolutely goes out to those people who cannot access mental health support that they need. This thing that Max talked about, that circular thing where, pain leads to mental health and problems and mental health leads to more pain, is such a big deal. And when we say we're fine, we talk about this on a regular basis. When we say we're fine, we know we're not really fine. But actually, to have support, mental health support as part of a course of treatment is essential, so that people will actually say to you, so you say you're fine, really? Are you really fine? And that's, for me, the thing that's really come out of this conversation is that there's a recognition from all the panelists so far that fine doesn't mean you're okay. Fine means that there's a backdrop of something going on that needs support.
Thank you, Raj. I wonder if we perhaps just bring Max Henderson back onto the stage, if that's okay, Max, and just to hear your reflections on the stories from Paul and Francis and Raj.
Can you hear me? I've unmuted myself.
We can hear you.
Oh, super, excellent. It's been quite an experience listening to the raw emotions and to the raw realities of what it's like trying to be a human being whilst having to struggle with these painful conditions. And I mean, I've been sort of typing away here a whole range of sort of thoughts and reflections on what it felt like just to listen. I suppose I have to sort of try to summarize it up. So the first thing, let's take it, when we as doctors of any sort of flavor come into contact with patients, we have them with us in that moment. But what we're really talking about here is a very long-term condition, and that takes a different level of understanding, I think, and that we need, as well as being with the patient in the moment in that clinical setting, we need to recognize that that moment is one example of what it's like living that life and being that patient and dealing with those difficulties. And not all conditions are like that, but recognizing that longitudinal element, that as the patient goes home and before they come and see you, that they're still struggling with those same difficulties. Obviously, when I wrote my presentation, I hadn't really had access to what everyone else was going to say, but the interest in employment is particularly interesting, and we might come back to that. But I'm really struck by something that I feel very strongly about, and that's about sort of networking and peer support and social isolation, and the role of contact with other people. It's important for me to say I'm not talking about loneliness here, because I do think that is different. Some people can be lonely in a crowd. It's about having the option to share, that option to validate, that option to have someone act as your sounding board, the opportunity just to unload. And I think part of what I was trying to get across, and I've heard it resonate in a number of conversations, is how a physical health problem like axial SpA can, with its pain and its impact on mobility and its impact on energy and sleep, make you withdraw. Now, many common mental disorders also do that, and the combination, I suggest, is probably multiplies rather than adds, and therefore the challenge of trying to come out of that is very much harder. And I think recognizing in medicine generally, I'm not sure that we've been as good at recognizing that as we should, and that's the sort of that human angle on that multiplicity of symptoms. So it's been quite humbling to have people so willing to share their experiences, and it does feel that I'm new to your group and I haven't been aware about how much work has been going on, but it does seem that you have an alliance of people whose ideas very much align with each other, and I think that the very act of so many people being here sharing seems to me that there's a lot of energy to try to move things forward.
Thank you, Max. Really, really insightful in comments, and just I think try and now move this conversation forward, Paul, you said in your presentation that you spoke very positively about the rheumatology department's care for your axial SpA, but you did say, my mental health has never been addressed, nor has there been a clear pathway of services or support for mental health, including post-diagnosis. So my question to all of you on the stage now is, ideally, what would you like to see in place to support you with both your axial SpA and your mental health? What would the ideal state be?
Would you like me to start there?
Please.
I'm very aware that my rheumatologist is on this call as well, but I did start my presentation by saying how fantastic they are with their care. But I think Ben was great in his explanation of why there's a kind of hole within that, and it's so much as there's a lack of funding and there's a lack of training. He explained that he hasn't had mental health training since medical school. So how could he possibly have the confidence to address those issues? I'm not sure what I would like to see as best practice, but you know, a healthcare psychologist or a health psychologist within that department certainly sounds like it gives people the reassurance to address issues more and at least discuss them. And I think once issues start to be discussed, you know, then we can start to get to the real root of things, because it's an ongoing process, as Raj says as well. It's cyclical. You'll never know when you'll feel down. You'll never know when you'll feel up. You know, a good day to us is not necessarily comparative to a good day to someone without a chronic condition. So there's very diverse areas within that as well. It's very, very difficult. It's very, very difficult to address and to turn into best practice. But I guess by opening this discussion today as to what is happening at present, I think that's the only way we can move forward, really.
Thank you. And Raj or Francis, any reflections you wanted to offer?
Yeah, I would love to jump in. I think that for me, there's a difference here between what we think is feasible today versus what I think would be ideal. Let's talk about what I would think be ideal. Ideal would be the same ways at the moment we see multidisciplinary practices effectively appearing in rheumatology departments, where we have the rheumatologist backed up by the physiotherapist who is an expert in AXPAR, or you know, and then we also have the specialist nurses as well as part of that team, to have within that team as well someone who's specialized in chronic conditions and the effect that chronic pain can have on long-term. I'd like to imagine, no, like is the wrong word. I can only imagine that there are other people who have suffered from chronic pain outside of AXPAR who could actually do with this kind of support, you know, very tailored towards the idea of long-term pain and the effects that can have on your mental health. And having those people accessing the same team, I think would make a lot of sense to me. Now, obviously that to me is the ideal. What it would take to do that would take a huge amount of investment and a bit of patience as well, because you can't just flip a switch and have these things happen. But what I know is, and this is from my, I should declare for the purpose of this conversation, I'm the chair of NAS. And you know, NAS has been around for 40 odd years now. And I know that some of these conversations take time. So I think with the right kind of focus, we could start seeing the right conversation going in the right direction, and then eventually a change in policy that will impact the care down the line. I'd love to see it happen sooner, but that, you know, that's the ideal versus the reality, I guess.
Thank you, Raj. Francis.
I'd like to suggest maybe, you know, one of those ways about getting that happening is about measuring it to start with, and discussions with patients. And I know it's really hard for clinicians, particularly when you can't then necessarily refer somebody on, but an acknowledgement that this is an issue, and questioning, you know, is this an issue for you? What might help? I think certainly in the meantime, there are opportunities, as Sue said, with the round table things, you know, promoting peer support. And our NAS group, Cambridge, we are now having regular chat sessions online, as well as doing a bit of exercise, because actually people have really found it useful just to be able to sit and chat and talk with other people who have the condition, who understand what it's like when you're awake in the middle of the night and can't do anything about it. But yeah, it's to begin to quantify it for departments to say, we know of our patients, this percentage are experiencing mental health issues, because until you sort of name it and label it and quantify it, it won't happen. It will just be an aspiration.
An incredibly good point. I think many departments really just don't have a strong sense of that. I want to thank the three of you for sharing your stories, and I think some important things emerging about what services ideally ought to be in place. So if I could please say thank you and then release Paul, Francis and Raj from the stage for the time being. If I can invite some of our clinical colleagues to join us, please. I'd like to bring back Ben Thompson. And maybe if we could also invite Helena Marx-Ortega and Anthony Chan, if they're happy to join us on stage, that would be helpful. And after doing that, Max, you said you work in liaison psychiatry, so you work with other departments. So do you work at all with rheumatology?
I do, and I have done, I haven't always been in Leeds, so I only unfortunately didn't cross over with Sophia at King's, but lots of what I've learned, I learned from David Scott at King's. So absolutely, I mean, liaison psychiatry, and that's why I sort of put that slide at the beginning, because this is an area of psychiatry that's relatively small, and many people won't necessarily have heard of it, and in a way you won't have heard of it unless you've accessed us. But we sit in the General Hospital, me and my team work in St James's Hospital in Leeds, but absolutely we work with, I don't think there's many departments in the hospital that we don't work with. We are a small team, so there's a limit to how thinly we could be spread. But absolutely, we exist to try to fill that role and to try to, as well as see patients who have particular difficulties where physical and mental health overlap. We exist to try to support and empower and sort of give heart and courage to our clinical colleagues to manage some of the mental health difficulties that they pick up in the clinical settings, because we recognise completely that when they feel unskilled and unprepared, entering those conversations can sometimes be uncomfortable and a bit daunting. But experience and evidence tells us that if you don't have far to reach out before you've got a clinical colleague who can support you, you feel a bit more confident in doing that. And so that the sort of, we talk in our team about having two customers, that the patients that we see are one group of customers, really important, of course, but the patients, doctors, the teams who refer our patients are the second and equally important customer, because sometimes by helping one clinician, we can help a lot more patients. So it's a potential resource for many of the challenges that we've been talked about today. It just needs more of us and a bit of expansion, because clearly I wouldn't I? But I strongly feel that that we have a skill set and we have a sort of a proposal that can meet a significant number of currently unmet needs. But these needs are often hidden, not talked about, not especially well captured. And it's by meetings like this, I suppose, where they're being brought out in the open, that we can start to work together to try to build resource to meet those needs.
Wonderful. Max, thank you very much. I can see from the volume of chat and questions, I think we could spend hours more, and sadly we don't have that this evening. So let's see if we can try and now focus some of the conversation. And thank you to have some of our rheumatologists here. Listening to what you've heard so far, the question is, what might best practice look like, and how do we start to build the business case in NHS organisations to integrate better mental health within Axial SpA services? So I'm happy to. Who would like to go first to that? Helena, Aisling, Tony. Aisling, please go on.
To start, I think what our wonderful the patients who've been on have said it all really. I think they've said it as clearly as any of us could do. We couldn't do it any better. And that is the starting point. It's the patient voice, it's their experiences. You know, it would be wonderful to, you know, to say that all rheumatological services would be able to provide the, you know, what Paul beautifully suggested was required. It would be, you know, brilliant to be able to do that, but we just don't have that resource. And, you know, most departments wouldn't have access to the kind of thing that's needed. And my usual trump card with patients is usually just a big hug, and I can't even do that at the moment because of COVID. So even that one's gone out the window. But I think the patient voice is really the starting point with all of this. And, you know, I mean, we've tried in our department, we're only a small department, our nurses are all being trained in health coaching and trying to use a more problem-based approach with our patients. And again, that's a step in the right direction, but there's so much more that needs to be done.
One of the comments that Ben made in his presentation was that the NICE guidance on axial SpA doesn't make reference to mental health. And the question is, I know it refers to other guidance, but ought it start to make reference to mental health? I wonder, Helena or Tony, if you have a view on that.
Helena, you want to go first? Yeah. Okay. So yeah, we certainly think that mental health is a unmet need that needs to be addressed. So we conducted an audit and found that 1/3 of our patients with XPA, even excluding those who had depression, had scored very high using the hospital anxiety and depression scale, either having anxiety or depression. And this was accelerated and made worse during COVID because of the stress of not being able to see our patients and with the lockdown. So we've been able to develop some self-management techniques. We've got a clinical psychologist. We developed a video, which I'll share with you in the chat after this. And that could be one way of trying to kind of deliver services. But we also understand that a lot of these patients do require one-to-one. So it's very important to kind of make the case that if we can deal with the mental health, that will definitely improve a lot of the outcomes for our patients. When we think of outcome measures, a lot of them are very objective. They're very much based on MRI or blood tests. But in fact, a lot of these outcomes are being affected by mental health that is unseen or undiagnosed. So unless we get that balance right, a lot of our treatment decisions and our plans will be affected by undiagnosed or unseen mental health issues. So this is why we think that we should put a strong case that clinical psychology should be very much part of our treatment plans. And this goes beyond the kind of physical or biological model of just seeing things, you know, by measuring, say, MRIs or CRPs. We need to go beyond that to make sure that the patients feel well when they receive the treatment.
Thank you, Tony. So, Helena, how do we build the business case within trusts to have psychologists, psychiatrists as part of the rheumatology team?
Now, wonderful question, Dale. You were going to ask me that. I'm just absolutely excited to hear all this and all the refreshness of all the messages that we've been hearing. And Tony has dealt on this as well. You know, the problem that we have is that we have not normalized mental health. And I think this is a huge issue. Yeah, our patients have got mental health issues that are associated to their condition, because who wouldn't? I mean, the rest of the population have mental health issues. Anxiety is common, depression is common. So if you have a chronic condition, you're even more likely to have this. So the problem is that we talk about physical health because there's usually things that we can see and do something about, but we do not talk about mental health. And by extension, that has been a problem in chronic health. And those of us who have been banging this drum for a long time in the National Health Service have always found that we didn't have the right interlocutors to talk to, yeah? And I'm delighted to see that people like Max work in Leeds. Max, I work in Leeds. I did my first business case 4 years ago, reaching out to the psychology team that works in chronic health within the LTHT Trust. And to my mind, there are different levels of health of mental health that are needed. And I want to believe that we don't need you as a psychiatrist. and that would be the, you know, the sort of a smaller pot, yeah, of our patients. Much as we would love to have that help, I believe that a lot of our patients actually do need clinical psychologists or counselors even. And I think that when we diagnose very early, one of the things that we need to do is actually try to address this need. And if we signpost people onto the right direction, we make them understand that it's normal to be anxious or even depressed about receiving a chronic diagnosis, I believe that a lot of them will actually not need further support. And we have shown this when we were building our business case. So what we did was exactly what Tony did. We needed data, we needed to convince people that we had a problem. So we survey our population of patients with axial SpA and other conditions. And then financial year went by, then there was no money. So then we needed to provide more data. Goalpost kept changing for 4 years. So that made us go and do an intervention together with our clinical psychology team. So we had the patient data saying we need help. And then we reached out to the clinical psychologist and we started sending people through, and we came up with the data that yes, 30% of near depression, 40% anxiety, but people were doing really well with just a short intervention, sometimes even 2 or 3 appointments with a clinical psychologist. So that was a lot of data. Another year, financial year went by, another goalpost. So then we needed to provide clinical cases. And it was only when we started to talk about the financial impact of getting somebody referred on time to talk about the problems and have the problems addressed and how we kept that people at work, that we kept that people happier, so they were not calling our helpline. That is when people started to listen. But what did it for us was, and Dale knows this, that the King's Fund reached out to us last year because they were doing a report on rare services who were dealing with under-recognized conditions. So they contacted us and they said, well, we know that you've got a large axial SpA service. Can I talk to you? And I said, I would be delighted, but our service does not deal with a rare disease. And we want to believe we're not under-recognized. We have a common problem, yeah, and we need to talk about it. So I love what everybody was saying today, because this is a big loop. And it's up to us to start breaking the loop, yeah? And the more empathetic we are, we just need to understand that the dots are joined, but that we can make a difference by breaking them up. So business cases need to be produced. Please all do. I would be happy to share ours, because I'm delighted to say that after 4 years, our managers have agreed to fund a full-time equivalent clinical psychologist and a counselor. And they only approved the counselor because I could prove that it was going to be cheaper. But it's a starter. I shouldn't say it's not a whole-time equivalent. I'm actually sharing them with dermatology. But there is light at the end of the tunnel. That was a long answer.
No, but I think that's an amazing success story, Helena. And if we can learn more about that business case and from Tony and others, and to share that with colleagues across rheumatology to help you marshal the arguments that you need to make, but also at the same time figure out what is the model of care that we optimally need. I feel that this APPG has been fantastic in surfacing the issues, but I feel we could probably have a follow-up meeting that actually starts to really get under the skin of some of these issues and think about what that might mean for future guideline development and PROMS measurements, and etc. Our time is sadly coming to an end fairly soon. So I want to thank our clinical colleagues here for your contribution. Our vice chair is Lord Campbell Savers, who, as you know, has Axial Spondyloarthritis, spoken about that. I wonder whether, listening to this conversation, he might have any reflections that he would like to share about the discussion so far. If we could bring him to the stage. But I think I will commit that we should, I think, to have a follow-up meeting of some kind to explore these issues in more detail and to work with Helena to bring together examples of business cases being constructed. Is he able to join us? It looks like maybe he's not. Okay. Oh, I can see possibly he is. Wonderful. Well, Campbell Savers, you're on mute still. If you can just unmute yourself.
I did. Have you got me now?
We have, thank you.
I did put a question on the chat line, and that was the incidence of people who have ankylosing spondylitis who find that they have to leave the employment market because of mental health issues. And I wondered if anyone really knew the answer to that. I mean, we've had the analysis today. We've had a brilliant session, actually. I've learned a lot during this session. But I just wondered to what extent it leads to unemployment, mental health issues when they interact with the condition.
Colleagues seem not to know the answer. Does anyone? Oh,
Yeah,
Helena, please.
There is data on that. There are data for, if you look, for instance, at people taking time to be diagnosed. For every year that the diagnosis is delayed, there is a near 10% increase on the risk of the person becoming work unstable. And by that means unable to not being able to perform well at work, or decreasing the chance of employability in the future. And we also know there is a direct relationship between that delayed on the diagnosis and the acquisition of mental health risk. Yeah, so there is a real, impact from both things together. And if you look at the old data from, years ago, 20, 30 years ago, it was over 50% of people who had symptoms for 10 years. They were already out of work with no possibility of returning to work, regardless of whether they had a diagnosis or not. And they had a mental diagnosis attached to that. So it's intimately related.
Sorry.
Can I just add to this? I mean, the reason why I asked this question, I've been in Parliament now for 40 years, 20 years in the Commons and 20 years in the Lords. And I've often thought that whilst I've been able to do my job in Parliament, if I'd been in different work outside, I wouldn't have been able to function at all.
Yeah.
So I think the nature of employment must surely influence to what extent people can work. And I wonder what help there is then generally to guide people more towards certain types of employment to avoid having to go into unemployment. And that's really why I was asking the question. It's only based on my own experience. I was lucky. I was in Parliament and I was able to handle it. But there are, if I was a builder laying bricks on a building site, I would probably go out of work for years, be unemployed for years. And I just, sometimes I wonder about these, that's all. That's why I asked the question.
No, it's a great question. Thank you, Lord Campbell-Savers. I wonder, Max, did you want to come in on that?
Yes, thank you very much. I mean, brilliant secondary observation there. I just was going to make a couple of points by way of response. So the first thing is just, in many ways, with respect to sort of wheel you a little bit back from the idea that sort of time away from work or sort of losing one's job has a single cause that we can identify. That can be slightly unhelpful because it's in a way it's born out of the old-fashioned sick notes, the FMED3s, which had room for only one diagnosis. Now, if you have more than one diagnosis, then how does the doctor know which one? If you've got three, how do you know which one has caused you to come out of work? Modern fit notes have the opportunity to give more than one diagnosis, but even then, we're back into the difficulties with multimorbidity, knowing how they relate to each other. And certainly my experience, and I've sort of spent 20 years working with occupational medicine, is that it's often, as I said in my talk, it's when there's an established longer term condition and then a mental health problem arrives on top of that, and that just upsets the stability that person has had, and down they go. So I think leaving the labour market is a complex and sort of pretty negative outcome, but it often arises from multiple conditions. With regard to your observation about the nature of work, that's fundamentally important because we've heard some of the speakers today talk about how positive and helpful their employers were, and unfortunately the higher up the ladder you are, sometimes the better educated you are, the better your employer, the more helpful they are. But I think that we need to recognise that there is a hierarchy in the quality of employment, and that those experiences are very much less common when we get to the bottom, when we get to people who are self-employed, when we get to people who have precarious in employment, who are in and out of low pain, no pain scenarios, that's extremely difficult. And often in those sorts of situations, I've just seen people just give up the idea of work. It's just too hard. It's just too much to offer, and that's fundamentally bad. That's bad for the patient, it's bad for their family, that's bad for society. So recognizing that these things sit on quite a steep social gradient, I think is really important.
Thank you so much, Max, and thank you, Lord Campbell-Savers, for the question. We need to wrap soon, but before I hand back to Tom, I want to say, first of all, I can see many of you haven't spoken and some fantastic comments. We will take these away and think about convening some additional meeting to explore more deeply some of the issues we've barely begun to explore this evening. But I hope you agree it's been a very, very rich discussion and so much for us, I think, still to think about and to take away. Let me please at this point just kind of end my part of the meeting by thanking all of you for great contributions, and now hand back to Tom for a final summary.
Well, thank you. And I was asked at this stage to sort of wrap up the meeting by talking about some of the main takeaways from today. And as I think, as everyone said, it's such a large area. It's difficult to summarize. But I think if I was to summarize it in one word, I take Max Henderson's word of raw. I think we've heard some really sort of powerful stories today. And particularly for those of us with AS, the subjects that we've touched on have really sort of gone to the heart of how we've been feeling and about ourselves and the experiences that we've gone through for many years. It's been a really, I think it's probably been one of the more emotionally difficult meetings that I've attended for NAS or just generally since I've been in this job. So I first of all wanted to thank all the panelists who have made their contributions, and Paul, Sophia, Ben, Max and Sue for their presentations. I think what I took out from this is that, you know, I mean, two stats I think which kind of summarize it very well is it was said that 1 in 6 will have significant depression, 40% with some depressed symptoms. And I know that mental health is an issue that is much more in the news now than we have perhaps talked about it before. But having this discussion, I think it's almost bizarre, isn't it, that here we have a medical condition which we can tell creates a lot of anxiety. Frustration was a word that came through a lot in these presentations, and yet actually marrying axial SpA and dealing with mental health seems to be something that we're coming to quite late on. But you know, obviously there's been issues with training, and you know, rheumatologists aren't trained to be necessarily mental health issues, which I think was an important point to raise. And but obviously there is a work that has been done on that, and I think provides perhaps a model for further work in the future. So I thought that was it was a really interesting discussion, not only to sort of establish the problem, but also really kind of pick out some of the sort of pathways to the future and possible solutions to dealing with this. But obviously such a big subject, it's not something we're going to be able to easily resolve either in one session or overnight in the work that we do. But I just want to say, so thank you. Obviously the APPG generally will be taking away these points, and we look forward to sort of raising this as a subject as part of our work and with NAS and other stakeholders to try and make sort of progress and take forward this issue. There will be minutes of this meeting which will be shared with attendees in the next couple of weeks, and yeah, so finally I just want to say, and it's been a long meeting, so thank you so much for taking your time, for the effort in the presentations. Thank you all for attending. It's been a really interesting session, and thank you for coming, and I very much look forward to seeing you all soon, hopefully in person at some point, otherwise on your computer screens. Thank you very much.